Dr. Rawat sir, good morning ma'am, and good morning to all the faculty, students, fellows who have made it this morning for this wonderful talk. So I would like to introduce Dr. Indu Khosla ma'am, who will talk about this program, the radiopulmonary crosstalk, and why it is so important. So, and ma'am, if you could say. And following that, Dr. Rawat sir could please share a few words about this initiative.
I welcome you all to this new initiative where we are going to do a clinico-radiological correlation. Every time when I reach SRCC Children's Hospital, in fact, yesterday only I told Dr. Hiren, I need a cabin just next to yours because I think pulmonology as a branch is quite incomplete without radiology. And we complement each other. So when they say clinically correlate, we tell them radiologically correlate. So it's a bilateral correlation. And with increase, with advancing time and the way radiology is, I would say the kind of techniques that are there today in radiology and reconstruction, it is such an added tool, and it I think improves patient care and our diagnosis. So without much ado, I think we will start this, and I'm sure we will all learn. We have to learn from the radiologist, and I think when we could clinically correlate with their findings, we will also get better. I invite Dr. Rawat on this platform, who I think has got unstinting support for any academic activity we do, and we thank you very much for this, and thank you so much for joining us today morning. Please, over to you, Dr. Rawat.
Thank you, Dr. Khosla. I bring greetings from IP Natural Respiratory Chapter. Good morning to all. And I think this is an excellent initiative by IP Mumbai for this program of pulmonology and radiology crosstalks. As Dr. Khosla has told, I agree with that. That pulmonology and radiology, they are very close ally. And radiology has come to rescue of pulmonology almost with simple problem like community-acquired pneumonia to complex problem like interstitial lung disease or congenital anomalies. It has always come to rescue. So I think this particular session where you will discuss more about nuances of radiology, where how it can come to rescue in complex problems. I think this is a great way of learning. And with people like Hiren Panwala on board, definitely you will learn more and more of finer details how you can use this particular modality, this very fascinating field of medicine to your rescue. So I'm also excited, and I hope that all the delegates on board, they will be benefited by this session. Thank you very much. I again wish best wishes from our association for this program. Thank you very much. Over to Dr. Indu, please.
Dr. Nehal Shah, our president, couldn't join in today because of her personal medical emergency at home, but she has also given us unstinted support for this. Over to you, Tanvi, when we can start the.
So without further ado, thank you ma'am, thank you sir for the support for this. I'd like to introduce Dr. Abhinaya, a second year pulmonology fellow at NHSRCC Children's Hospital, Mumbai. Dr. Abhinaya will be beginning with the case presentation, and we're titling this Behind the Bleed, an Illusory Puzzle. After the case presentation, we will have a discussion and a review of literature, first by the radiology expert, Dr. Hiren, and the pulmonology, of course, Dr. Pindu Khosla. And the management will be discussed by the expert, an eminent interventional radiologist, Dr. Monal Bhutta sir, who will be joining us shortly. So Dr. Abhinaya, you can please begin the case presentation.
Good morning, everybody. Thank you so much for this opportunity. I shall begin my case presentation. I am Dr. Abhinaya. I am a fellow in pediatric pulmonology at SRCC Children's Hospital. As told by Dr. Tanvi, our experts are Dr. Indu Khosla ma'am. She will discuss on the pulmonology aspect. Dr. Hiren sir, he will discuss on the radiology aspect. And Dr. Monil sir, he is our interventional radiologist. So I shall begin my case. Our case history is 8-month-old girl child First by birth order, born out of non-consanguineous marriage, she presented to us with complaints of recurrent episodes of spitting up of blood since 5 months of life. This episode started in October 2024, where she had initially started having cold, wet cough for 7 days. At the same time, mother also had some upper respiratory tract infection. Baby brought out blood after coughing. It was scanty in amount, and the child had 2 episodes. There was also associated dark colored stools, and there was no history of any other complaints, no fast breathing or no fever. Because of this, child was admitted in a local hospital and child was observed and evaluated for the cause of bleed. Her coagulation profile was found to be normal and there was occult blood and stool and child was stable during the ward stay and then they had advised upper GI endoscopy after discharge. So, and this is the her X-ray on admission in October 2024. We are able to see that X-ray is rotated, thymus is prominently seen. Otherwise, the chest looks unremarkable at this visit. In November 2024, the child had undergone upper GI endoscopy, and the findings were in the stomach there was prominent vascular pattern in the fundus, but there was no other evidence of bleeding, blood, or ulceration. Duodenum showed some features of some 3 nodules with ulceration and white macules in the adjacent mucosa, and biopsy was taken and sent for analysis. This is the endoscopy picture where we are able to see some prominent vascular patterns and some white macules. Otherwise, the upper GI endoscopy was also essentially normal. And this is the histopathology report, which showed some mild chronic duodenitis and some reactive lymphoid hyperplasia. Based on the clinical presentation and the histopathology report, the primary physician had suspected cow milk protein allergy, and then they had completely stopped cow milk from baby and mother, and child was also on infant formula, which was stopped. The child was started on soy-based infant formula, and the child was continued on breastfeeding and complementary feeding and started on iron supplements. But even after stopping the cow milk, child continued to have similar episodes in the last week of November with cold, cough, and bleeding. These episodes continued in December also. The child had cough, cold, with coughing up of blood and black tarry stools. And these episodes were recurrent throughout December, especially in the first week of December and then in the last week of December. The child came to us in January. On further questioning, child was not gaining weight since last 2 months, and there was also history of oil installation in nose, and there was no history of fever, fast breathing, no history of TB contact. There was no history of rash or bleeding from any other side or injection site hematoma. There was no history of vomiting, loose stools, no history of coughing while feeding, and there was no history of successive cycle or forehead sweating. And the child had normal urine output and then no history of blood in urine. The birth history showed mother had 2 abortions. One was a spontaneous abortion, and the second one it was an MTP because of query anencephaly in the child. Mother also had PIH and anemia during this pregnancy. The child was born full term LSCS, but the birth weight was 2.3 kg. Child was small for gestation age. Child cried immediately after birth, and there was no significant perinatal event, no NICU admission. Child was on both mixed feeding, bottle feeding, and also on breastfeeding. Development history, it was almost normal. Neck holding in 4 months, rollover at 6 months. Now the child was sitting with support. Fine motor, bidextrous approach. Language, child was able to say bisyllables. And socially, there was no stranger anxiety till now. And child was immunized as per the government schedule, and BCG scar was present. Family history, there was no relevant significant family history. The father was a smoker and there was one MTP in the mother. And the parents belonged to lower socioeconomic status. So the summary based on the history is the child had actually had coughing up of blood for, after each episodes of URI or cough and cold. The child had coughing up of blood. So hence the child had a hemoptysis rather than hematemesis. So this is a 8-month-old girl with recurrent episodes of hemoptysis with occult blood and stools with failure to thrive. On examination, child was vitally and hemodynamically stable. Heart rate was 120 per minute. Peripheral pulses were well felt. There was no respiratory distress. Child was maintaining in room air and CRT was less than 3 seconds. AF had left. The significant positive findings were pallor was seen. AF was at level. Mild frontal buzzing and depressed nasal bridge was seen. Anthropometrically, child was also small for gestational age at birth, and child was not gaining weight in the last 2 months. Her length fell in the -2 standard deviation. Weight was also in the -2 standard deviation, and head circumference in the -1. Systemic examination revealed cardiovascular system. There was no murmur heard. In respiratory system examination, RNT was bilaterally heard equal in all the areas, and there were no added sounds. Abdomen examination revealed liver was just palpable, normal liver span. Spleen was also just palpable, and CNS also revealed normal tone power, and there was no focal neurological deficit. So now we are dealing with an 8-month-old infant with some hemoptysis. So now let us quickly recap what can be the causes for this hemoptysis in an infant or a child. So the most common cause according to the literature is infection. So any infection can cause bleeding like bronchitis, bronchiectasis, which is uncommon in this age group, tuberculosis, lung abscess, pneumonia, or any trauma, for example, in after intubation, after tracheostomy, airway laceration, foreign bodies can cause hemorrhage. Other rare causes include vascular disorders like AV malformation, hemangioma, embolism, thrombosis, coagulopathies can also present with hemorrhage, and congenital lung malformation like sequestration, CPAMS, bronchogenic cyst, and diffuse alveolar hemorrhage syndromes. If we see diffuse alveolar hemorrhage syndromes, there are actually two basic broad categories. These categories include immune mediated and non immune mediated. When we say immune mediated, basically ANCA and other ANA, they are all positive, and this is rare in this age group considering the infancy. So the immune mediated causes include generally the granulomatosis with polyangiitis, microscopic polyangiitis, anti-GBM disease, SLE, Henoch-Nolan purpura, Besser disease, cryoglomic vasculitis, JA. And there are two new entities which are described in the review of literature, which are the COPA syndrome and the SAVI syndrome. COPA is a newly described entity, which is cotomer protein complex subunit alpha. In this disorder, there is actually a problem in the trafficking of the proteins from the Golgi apparatus to the ER, which results in ER stress, autophagy, and finally, which results in interferonopathy. And similarly, seen in Savi syndrome, which is nothing but sting-associated vasculopathy with onset in infancy. All these disorders are very rare, but they can present as pulmonary bleed, and they can have cyst in the CT scan, and they also have associated condition renal involvement. So all these things have to be kept in mind, though it may be rare. In non-immune mediated causes is the commonest causes including Hennes syndrome, which is the pulmonary hemorrhage secondary to Cormel allergy, something called as the Lane-Hamilton syndrome, where the children can have pulmonary bleed with celiac disease. The celiac disease can be symptomatic or asymptomatic. Cardiac causes can commonly cause pulmonary hemorrhage. We all know they are pulmonary stenosis, TAPVC, pulmonary veno-occlusive disease, mitral stenosis, left-sided heart failure, and other conditions like pulmonary capillary hemangiomatosis, pulmonary cholangiocarcinoma, even abuse, or there are rare condition like acute idiopathic pulmonary hemorrhage of infancy and IPH can all cause hemorrhage, diffuse alveolar hemorrhage. So after reviewing the literature, we did appropriate investigations. CBC showed hemoglobin of 9, MCV of 69.66, low. TLC and platelets were all normal. And iron profile showed iron deficiency anemia. Ferritin was low and transferrin saturation was low. TIBC increased. And the coagulation profile was done, which was normal. And thyroid profile was done normal. And serological markers were negative. We were also suspecting cow milk protein allergy and celiac disease. So all these evaluation also came negative, and 2D echo was done, which was normal, and ANA was negative. Since we were suspecting pulmonary hemorrhage and already GI workup had been done from the previous hospital, we had done a bronchoscopy in this child. So let us look at the bronchoscopy video. So after, I hope it's clear? Is it clear? So, after entering through the nostril, we are just above the epiglottis. If you can see, we are able to see epiglottis in almost in the middle of the screen, and we are able to see some blood spurting up, and we are able to see there is some cystic, semicircular cystic mass which is seen just above the epiglottis in the vallicular region, almost touching or abutting the epiglottis. Is it see it's seen clearly now? We are able to see the epiglottis, and on the top of the epiglottis we are able to see some cystic globular mass almost abutting, touching, and almost compressing the epiglottis. So now we are entering the trachea. So I'll just quickly show. The trachea was all found to be normal. We had then saw the right subsegments. They were all found to be normal. There was no bleeding seen, nothing seen. Now I'll be showing you the left side. So left side, as we entered, we had initially entered the lower lobes. They were also were found to be normal. And now if we carefully see, this is the left upper lobe. We are able to see some erythema in the left apico-posterior segment. And if you see very carefully, the blood is, if you see, I'm just pausing it now. So if you see, the blood is actually spurting from the left upper lobe. I hope it's visible. Again, I shall show you that. In the left upper lobe, we are able to see some erythema. And if we look very carefully, there is some pulsatile movement is seen, and we are able to see the blood spurting from the left upper lobe apico-posterior segment. So after this bronchoscopy, we were sure that there is definitely a bleed which is coming from the left upper lobe, but we were also concerned about the mass which is sitting just above the epiglottis. So we were thinking what could be the causes of the cyst. So the most common cause in this particular age group is vallicular cyst, or relevant to our case, is it any hemangioma, lymphangioma, or is there any thyroid, ectopic or lingual thyroid sitting over there, or a thyroglossal cyst? But on history, there is no history of stridor or noisy breathing, because this is just sitting just right above the epiglottis. And also the DDs of the left upper lobe bleed. It could be most common cause like infection, or we were thinking, is it some ALV malformation present? AV malformation present resulting in this bleed. So now we had done a BAL analysis also. The gene expert MTB was not detected, and BAL culture there was no growth. In cytology, it was showing a hemosiderin, almost 50% macrophages had hemosiderin laden macrophages were present. So we were sure this is a pulmonary bleed, and there was no TB or there was no infection. So because of this clinical picture, we were concerned about the bleed and also about the mass. We had subjected the child to MRA neck to look the etiology of the mass, and also a CT chest with pulmonary angiography. Now I invite Dr. Hiren Panwala sir, who is our consultant radiologist, to discuss on the uh, further radiological discussion. I have stopped screen sharing. I invite Dr. Hiren sir.
At this juncture, Abhinay, thank you so much for your presentation. So while Dr. Hiren shares his presentation, there are a few questions for you on the platform, which says, why did you presume it was hemoptysis and not any other bleed? And was an ENT examination done?
So, ma'am, yes, we were also like, as the previous doctors, they had the history actually said the child had cold, wet cough, followed by actually coughing up of blood. Though there was blood in stools, it can be actually swallowing up of the blood. And the outside doctors had already done a GI evaluation, and otherwise the child did not have any nausea or a vomiting feel during the episodes. And mother was typically saying child was coughing and the child was bringing up the sputum, even though since the child has already been evaluated for the GI causes, we first did a causes for evaluation of hemoptysis. ENT examination, we had.
We have a fresh blood coming out from the GI tract. At this age, a child of just about 8 month old, the only fresh blood which we can think of is something like a Mallory-Weiss syndrome, where a child might forcibly bring out blood. But this kid was too small for something like this. And of course, the GI scopy did not show any hemangioma in the GI tract or any polyp or anything which could cause it to be blood. And it was fresh blood. What the child was removing was fresh blood. So, generally in from the GI tract, apart from Mallory-Weiss, which will come with fresh blood, you will have altered blood coming from the upper GI tract also because of the acid content in the stomach. Okay, what about the ENT evaluation? Could it be an upper airway bleed? You saw a mass also there. Could it be something from the mass that was there?
So that's why we had that's why we had a bronchoscopy. In bronchoscopy, we also go from the nose and also we see the upper airways. So that's where we found the mass which was sitting over there. Other than that, it was all normal.
Okay. Yeah, go ahead, Dr. Hiren, over to you. There is
Yeah,
a
yeah,
call.
I'm sharing. First of all, thank you very much for taking this initiative and starting this pulmonology and radiology discussions. That will help us also to gain some clinical knowledge when we are reporting the CT and X-ray films. So, without wasting much time, I'll start the imaging what we had done at SRCC. So, as Abhinay told that there was a doubt regarding a lesion at the oropharynx or base of the tongue area. So we did MRI for that. First of all, the first take home point is that when you are dealing with neck or oropharyngeal or any laryngeal lesion, the imaging modality of choice is MRI because CT sometimes doesn't give you that much of a high resolution between different soft tissues of the oropharynx and larynx. So that anatomy is better seen on MRI as compared to CT scan. Many times we are not able to differentiate solid lesions from cystic 100% on CT scan images. On that also, MRI scores more over the CT scan. So the first take home point that it will save the radiation and it will give you better tissue characterization and better anatomical localization, especially in small babies, in which the airway and the pharyngeal structures is immature and they all look the same, and it's the distinguishing between different structure is very poor on CT images. So that's why we did MRI. So when these are the MRI star images, basically it's a fat set, but it will highlight the fluid signal intensity areas. And what we can see here that there is a well-defined like T2 bright or stir bright lesion, which is located at the posterior part of the tongue at the base of the tongue. And this is the location of that foramen cecum. Uh, and if you remember your embryology, that the thyroglosal duct cyst tract that starts from this foramen cecum and it goes down, and in relation to hyoid, it's reaching up to the thyroid bed subsequently. So what we are seeing that there might be some sort of anomalous descent of the thyroid duct, which has led to this kind of cyst formation in that foramen cecum area, which is giving rise to this well-defined cystic lesion. It's T2 bright. I'll show you on the Excel images also. Uh, 1 minute. Yeah, so these are the T2 weighted Excel images. And this is the level of thyroid gland. So we can see thyroid gland on either side. That is the airway, the trachea we can see here. And I'm coming at the level of base of the tongue. So here is the base of the tongue and the posterior part of the tongue. In here we can see that there's a well-defined T2 bright lesion, which is in central part of the posterior aspect of the tongue. And it was not showing any adjacent inflammation. Sometimes infection in thyroglosal duct cyst can happen that can cause secondary bleeding or secondary febrile symptoms, but that was not the case. We also have to see the T1 weighted images because sometimes developmental cystic lesions like dermoid can occur in this location, very rarely, but can be there. So we have to see the T1 weighted images also. T1, it was very hypo-intense and there was no obvious fat content within it. So it was not looking like dermoid. And it was not looking like thyroid gland also because this might be a location for ectopic thyroid in the lingular region, but it was not following the signal intensity of the normal thyroid gland. So based on that, it was not fitting with the ectopic thyroid also. So concluding all this imaging information, we also did the contrast because on contrast we can say whether the lesion is solid or cystic, and further characterization can be done. So I'm just showing you the post contrast images. Yeah, so these are the post contrast images in which we can see that, yeah, this is the lesion. So that is not showing any obvious enhancement. I'll show you on sagittal so that we can delineate better. So these are the T1 fat suppressed post contrast images. You are seeing that lesion is more predominantly hypo intense. It is not showing any areas of solid enhancement and no peripheral enhancement. So it is behaving like a very benign developmental cyst. So, and looking at the location, it was very well fitting with the thyroglosal duct cyst. So based on that, we concluded that the base of the tongue and that posterior part of the tongue, that lesion is the thyroglosal duct cyst. That may not be the cause for the recurrent bleed because it was not showing any feature of inflammation or any other obvious ominous sign. We also did the CT scan with contrast. Before that, I just wanted to show the radiograph that we had done while the patient was admitted for these procedures. And in contrary to previous radiograph, we can now start seeing that in the left upper zone, here in the perihilar suprahilar region, we can see abnormal radio opacity. Uh, for that reason also, we had done the CT scan since the child had was like recurrent hemoptysis or recurrent history of blood from the mouth. Now I'll be showing you the post-contrast images. First, I'll be showing you the lung window. So these are the lung window images, and as we go lower down, this is the airway. Uh, this is the narrowing part of the larynx, that is the cricoid, and now we are going to the cervical trachea. As we go lower down, now the thoracic trachea will start. The trachea will have this kind of posterior bowing, that is a normal thing. As we go lower down, now we'll be able to see the carina. Now the carina is dividing into right and left main bronchus. And so throughout the airway, we could not see any obvious areas of abnormality or any focal lesion within the major central airway. But now, if you focus here, that we have started seeing something areas of collapse consolidation in the left upper lobe, which is more in the posterior segment and the apical segment. That area was showing this kind of cystic changes also, like some sort of cavitation, which could be post-infectious. Uh, so when you are looking at those kind of finding in a post-contrast image, always look at the mediastinal window also, because sometimes the findings may not be apparent on the lung window. You might miss some sort of anomalous vascular supply or anomalous enhancing tissue. So for that, you should always 1 minute. Yeah. You should always uh, see the mediastinal window also. So this is the post-contrast mediastinal window. Here, what you are seeing that yeah. So now just focus on this area. So this area, the periphery of the area shows that non mildly enhancing college consolidation, but you can see that there's some sort of abnormal extravasation of the contrast, which was not seen on the plane scan, and you can see that yeah. So this is the main pulmonary artery. This is the left pulmonary artery, and from the left pulmonary artery, you can start seeing that there is one branch which is extending to this area. Yeah, you can see that is going to this area, and then yeah, here also there is one more branch here. This is also a branch from the left pulmonary artery, and that is going upward, and then it is extending into this collapse consolidation. And you are seeing some sort of anomalous dilated tortuous vessels and abnormal extravasation of the contrast here in this location. We are not seeing any abnormal short or wide neck aneurysm, but we are seeing anomalous channels. And you can see that from these anomalous channels, there is some sort of venous drainage. So this is a vein. If you follow that anatomy, it is draining into the left upper low pulmonary vein. See, this is the left upper low pulmonary vein, which is draining ultimately into the left atrium. And from this anomalous tuft of vessels, that that vein was coursing and draining into the left upper lobe pulmonary vein. The same finding I wanted to show the coronal images also, so that you have better uh, perspective and better understanding, because I know that we are more used to or more comfortable with the coronal images. So these are the coronal mediastinal window images, again post contrast, and that is the main pulmonary artery. the main pulmonary artery will divide into right and left. So this is the left pulmonary artery. And that now we can see that division of the left pulmonary artery into segmental arteries. And here you can see that from the posterior aspect of the left pulmonary artery, there is one segmental branch is going into upper lobe into that abnormal collapse consolidation area. And now you have started seeing this anomalous channel. One more channel you can see from here that is extending into that area with which is looking like some sort of contrast extravasation and having anomalous venous drainage into the left upper lobe pulmonary vein. So it was considering the age of the patient and this kind of recurrent history. It was looking like some sort of a vascular malformation which might be there from birth or before that. And looking at the strong arterial supply and the venous drainage into the left atrium, into left pulmonary vein, we thought of this look like more of a vascular malformation, either pulmonary AV malformation, or it could be some sort of rupture or erosion of the pulmonary artery, segmental artery branches, which could have caused this kind of extravasation and that could have caused recurrent hemoptysis in the past. So that was our presumptive diagnosis on the CT scan. Uh, any doubt till now? Anybody wants to comment or have questions?
I think Dr. Hiren.
Hi, Dr. Hiren, this is Dr. Monil here.
Yeah. So Dr. Manil, I'm coming to I'm handing over to you to for the further that DSA images. I'm having DSA images.
The-
So yeah.
Yeah, just one thing I wanted to add now. See, what happens on CT scan, especially in pediatric patients, now,
Hmm.
because of the small size of the arteries, there is always a confusion whether the feeders are arising from the pulmonary arteries or from the bronchial arteries.
Yeah.
What happens is similarly in this patient, like I remember embolizing, I think around 6 feeders, but
Hmm.
all of them were from bronchials and intercostals rather than actual pulmonary.
Okay.
And that the thing is what the arteries, especially the bronchial arteries and all in pediatrics, they're so small and they are so much
Okay.
in proximity with the pulmonary arteries. That kind of like a confusion always happens. So
Okay.
even with this child, I like the pulmonary circulation as such was normal. It was mainly the bronchial arteries which was supplying the AVM, and it was a very high flow AVM.
Okay.
Yeah.
Can I show your this thing DSA images?
Please.
Yeah. So just help me because I
No, no,
like we have loaded
absolutely.
all the series. So help me in which one to show. I'm starting from the beginning, right?
Yeah, please.
Before that, anybody has any doubt regarding CT scan? Any discussion for that?
I think Dr. Hiren, you have done a very wonderful job of very clearly explaining to us. So here, then the thyroglossal cyst, what we were saying, it was not really reason for the child bleeding. So our one of our differentials was whether it is a hemangioma on top, right? So here the child was clearly bleeding from the AV malformation, and that was just a thyroglossal duct cyst and nothing to do with that. So that became very clear from how you nicely explained about the cyst and the fact that the bleeding was from below. There was one query which was not radiological but which was clinical, which was from Dr. Monil, which talked about when we have Hiner
Final.
syndrome. Hiner syndrome is non-IgE mediated hypersensitivity. Is there a role of doing cow's milk specific IgE? So, Dr. Monil, cow's milk allergy could be IgE mediated, non-IgE mediated, or it could be mixed, right? When we do specific IgE to cow's milk, but that picks up only about uh, less than 50% of those children who have cow's milk protein allergy. So therefore, it is more of a clinical diagnosis, though we may do a specific IgE, but you have to stop milk in the mother's diet if the mother is breastfeeding, or milk in the child if the child is top fed, milk and milk products to see if there is any response. IgE mediated response is quite quick, whereas non-IgE mediated may take up to 1 month to show a response. So though we may do a test, but the diagnosis is clinical.
There is one more question in the chat box. There were some duodenal lesions. What were they? If Dr. Abhi.
The duodenitis? Yeah. Abhinay, want to answer that?
Dr. Abhinaya could answer this.
Yes, ma'am. So they had mentioned from the outside GI endoscopy that fundus had showed an increased vascular pattern and that the duodenum had shown some white macules, but they were subjected to endoscopy and an endoscopy had showed reactive lymphoid hyperplasia. So that was essentially nothing major.
Okay. Dr. Monil, and Dr. Hiren, you can go ahead with the.
Can I, sorry, can I interject for 1 second?
Yes, please, Sonal.
Yeah, Dr. Sonal here. Hi, good morning, everyone. Okay, so as I just wanted to add one thing. So as Dr. Indu said that the thyroglossal duct cyst was just a red herring and it really had no relation with the bleed. And because of your findings on bronchoscopy of those lesions near the airway, so immediately we decided to do a CT scan in the patient, even though the patient was referred only for an MRI. But the one more important thing I wanted to add is that in any child of hemoptysis, when you plan a CT scan, you must always plan it as an angiogram, not a CT chest plain, not a CT chest with contrast, but a CT angiogram of the chest, which we plan like a pulmonary angiogram. So as Dr. Hiren could show all those arteries and veins, all of that is only possible if you plan the scan as a CT pulmonary angiogram, not plain or with contrast. So that should always be part of the imaging workup in a child with hemoptysis, an angiogram if required. Yeah, that's all. Thank you, Dr. Monil.
Thank you, ma'am. Uh, so there's one more question for radiology before we move on. That the X-ray is not showing any collapse or consolidation on the left upper row, upper
No.
lobe.
So yeah, I think the last radiograph that what we did in SRCC, that is showing. I can show that X-ray again 1 minute. So that's why that also was one of the reason why we wanted to do CT scan, because we did something. Yeah, so this was the radiograph that we have taken at SRCC, and you can clearly see that there was some sort of abnormal airspace opacity in this region, in the left upper and mid zone area. So to further characterize, like, are we dealing what with, because it's a small child, are we dealing with some sort of congenital lesion which has got bled, or again that's some sort of vascular malformation which is the cause for uh, this kind of symptoms, or a child had some sort of uh, TB, though it is rare, which is the cause for the recurrent bleeding. That's why we go ahead with the CT scan with contrast and angiogram.
Sure. I think we should go ahead.
Yes, sir.
Amount
Yeah,
of time.
so just showing some sort of DSA imaging, Dr. Monil did the procedure, and I would like to invite him to explain the images. Dr. Monil, yeah,
Yeah, I'm here.
you can guide me like which series to
No, no.
show or something.
Yeah, so start from the beginning. These are the super selective images.
Yeah,
Summarized plastic.
yeah. So
Yeah, so
Dr.
this is the
Monil, yeah,
first what we do the basic aortogram.
yeah.
Okay.
So if my understand, this is the left pulmonary artery, right?
No. This is the
This one.
aortogram.
No, aorta is this one. After
Yeah.
that, relate what you are seeing, this one.
So that's what. So that basically is an looks like an early draining vein from the nidus of the AVM. If you play
Mm,
it on blue,
mm.
yeah, and play the next image where I've cannulated the feeders.
Yeah,
So even in this, you can see the bronchial artery, no?
Absolutely, you can.
Yeah,
Absolutely can.
yeah,
No,
yeah.
yeah, this one you can see it better.
but this
Yeah.
bronchial artery were not clearly, as you said, and it was not clearly seen as a dilated tortuous on CT scan.
No, see, honestly speaking, these
Yeah,
bronchial arteries will never be seen on CT scan because what
yeah,
happens now? They are very, very small. See, the catheter which I have used, if you everyone can appreciate the catheter, that's the smallest diagnostic catheter we have, which is like 4 French, which is
correct, correct.
basically the diameter of that catheter is 1.3 mm.
Mm-hmm.
If you see the artery, that those arteries are even smaller than the diameter of my catheter. So there's
Yeah,
hardly 1 mm. So it is impossible to pick up these bronchial arteries. Like forget children, even in adults, sometimes we don't pick up the bronchial arteries, especially when we do
mm,
embolus for Cox patient when they have hemoptysis. They have
okay.
bigger intercostals and bronchials. Still, they don't pick up. Yeah, where the mouse cursor is, see that is the tuft of vessel which Dr. you were seeing on the CT scan. And
Yeah,
if you see like a blush, like a like an pencil shading kind of a appearance, that is the
yeah.
extraversion of dye what we were seeing on CT.
Mm-hmm.
Now, here
Yeah,
the biggest challenge, especially when it comes to such AVMs, is finding out the number of feeders and treating the nidus. Now, the
mm,
difference is if I just coil the artery, which is supplying, it will not do my job because the nidus is still patent. If the nidus is still patent, these AVMs has a characteristic of drawing blood supply from other surrounding arteries. So that's why here what used to happen now, because this nidus, this AVM was a complex AVM. It had approximately, I think, 6 feeders. So
Okay.
as we go ahead, see, as you move ahead, you will see once I start super selectively cannulating it.
Okay.
Next.
This
Yeah,
one?
so this was like a big bunch of intercostal arteries, and you can see the blush going there on
Yeah.
the right side. That's
Yeah.
like that's also contributing to the AVM.
Okay.
Yeah, go ahead.
Dr. Monal, this tortuosity of the vessels is normal appearance or these are abnormal, right? Like
No,
these are
no,
extremely tortuous.
no, this appearance of the intercostal is normal. They're always like a
Normal.
zigzag
Okay.
pattern. Yeah, they're always like a zigzag pattern.
Okay. This corkscrew, like very tortuous appearance.
Correct. So see, now we're going out with the finally after putting the, so here we have embolized using two type of embolic materials.
Hmm.
First, after cannulating with the diagnostic, see, yeah, this is super angio. You can see that I've gone super selective with the micro catheter, and when I've
Yeah.
injected from the micro, you can see that entire blush lightening up. That entire AVM is lightening up. And now
Mm-hmm.
you can see the draining vein, a very beautiful draining vein at the center part. If you can just play it again, this video. Yeah, that's the draining vein. Play it on loop, then you'll see it better. Yeah, now just see. That's the nidus, and then the draining vein comes so fast. Got it?
Yeah. Yeah. Yeah.
So here what I've done, I've embolized using two types of embolic material. One is PVA particles, what we call polyvinyl alcohol particles.
Hmm.
They are mainly specifically designed to ensure that the nidus of the AVM gets packed with the embolic material. And once we do that, the parent artery we coil it with we close it with coils, just to ensure that no other parasitic feeder eventually comes. Yeah, that's the coil coming out. If you can appreciate, that's the coil which is
Yeah.
coming
Yeah.
out.
Yeah. This one is the coil.
Yeah. Next.
Great.
So similarly, like I said, I think there were around 6, 7 feeders which I had to knock off. You can just
Mm-hmm.
keep going ahead because there'll be multiple feeders.
Yeah. Yeah. Yeah.
I think the second last one was the biggest, which was like a very nasty one.
Mm-hmm.
Yeah, play this one once. Yeah. No, not this one. This is a very small one. Go down, go down. Yeah, play this one.
So, Dr. Monal, what is this
Yeah,
embolic
yeah,
material? Sorry, you
yeah. Please,
mentioned
please
it,
go
but
ahead.
can you?
Yeah, so for embolization, there are different types of materials which we use in intervention radiology. There are some which are known as particulate, some which are known as
Hmm.
liquid, and some which are known as solid. Now, particulate means is mainly what you call the PVA particles, that is polyvinyl alcohol particles. And second one is what you call gel foam, that is Abgel, the routine gel foam which is used in surgeries also. Then is liquid embolic agents, like there are different types of glues what we use. But in AVMs, glue we usually don't prefer unless there is an internal AV fistulization of the AVM. Sometimes what happens, the AVM is so high flow that within like half a second only the vein starts coming up. So in that case, we usually prefer using liquid embolic material that we usually do in pediatric brain AVMs. In that, we usually prefer liquid embolic agents. And the third one is what we use is what I've used is called coils. See, now you can see this one was as a big feeder. I think you can go ahead. I basically entered this.
Yeah. So, but yeah, I got your point. But still, like,
Yeah,
see this.
Dr. Hiren, see here you
Hmm.
can see the bronchial a little prominent. Just go one frame back, one frame
This
back.
one.
Yeah, can you see that?
Yeah. Yeah. This is very
Yeah,
prominent, very dilated.
yeah, that's a little prominent bronchial artery.
Correct. So, morning I was reading about the treatment of
No,
AVM.
so
They
sorry, your
say that
voice
if
is cracking.
the feeder
Sorry,
diameter
your
is
voice
more
is
than 3
cracking. I
millimeter, they
lost
are
you.
prone for. Acha, can you hear me now?
Yeah, now I can
Now
hear
it's
you,
good.
please.
Yeah. So, what I was referring today about treatment of this pulmonary AVM, they were saying that if the feeder diameter is more than 3 millimeter, they are prone for recurrent hemorrhage, and we should coil those feeders more aggressively.
Correct,
Something like that, is
correct,
that?
correct. Absolutely right. See,
Yeah.
what we do now, see, if for example there are AVM which usually have only one or two feeders. Now,
Hmm.
one or two feeders, that means we assume that the AVMs are not that aggressive in drawing blood supply from other arteries. So in that case, once you treat the nidus, even if coil is a plus minus, you can leave it. But especially when you have I'll just stop and show this image. See, now you can see now there is some sort of stasis of the dye which is happening in the AVM.
Yeah.
And you see that is stasis of the dye. So for us, that's a very positive sign that now the blood supply to the AVM has significantly dropped down. That's why the
Yeah.
dye which was injected has now become a static in the AVM.
Hmm.
Yeah. And coming back to your question, so what normally we prefer is that if we find that there are multiple feeders, then it is always advisable to coil the multiple feeders so that we ensure that future recurrence chances are much lesser.
Hmm. Okay. Okay.
Yeah, play this one. Play this one. Yeah, see another one. You saw that?
Hmm.
So this was basically a in that same vicinity, but it is like what we call it was like a piecemeal supply. So like a giant AV, like a large AVM, different areas having different supplies from the different arteries. Yeah, even this one
Hmm.
was big, I think.
So that highlights the role of doing DSA under pressure, because these arteries and these collaterals, the
Absolutely,
larger
such
extent what
like
we
I
are
said,
seeing,
na,
that is
such
not seen at all. Yeah.
small arteries, it is impossible to
To
visualize on
see on.
CT scan.
Yeah. Yeah. Yeah.
Yeah, see even
Hmm.
this one, another one. Play this one, play this one. Yeah, you
Hmm.
can see that.
Oh my God.
And I remember I think we ended up using some huge amount of coils because we did even honestly even I didn't anticipate that it'll have so many feeders.
Hmm. Okay. I think this is a post-check aortogram.
Yeah, so this is the final aortogram. So what we always compare the before and the after. So if we compare it with the first aortogram where we could see that giant blush popping
Yeah.
up on the
Yeah. Yeah.
left side, that entire thing is settled. Of course, we put a
Correct.
lot of coils and everything, but see one thing now which I don't remember who's the resident looking after it. Every
Hmm.
12 hourly, I used to ask the resident to look for only one thing, and that was whether the child is moving both her lower limbs or not. The reason is that the artery of Adam Kiewicz very commonly arises from the bronchial artery. So
Okay.
whenever we are embolizing anything in the bronchial artery, be it a child or be it an adult, for the first 12 hours, we always keep a strong watch on the lower limb movement. Because there's a very short, small incidence of, you can say, hardly around 0.1%, but there is a risk of paraparesis. So
Yeah.
here
Okay.
also, what I use, like, of course, on DSA, you locate the spinal artery and you always embolize distal to the spinal artery. But there is always that 0.1% chance that some embolic material may slip into the artery of Adam Kiewicz.
Correct.
So any bronchial artery, especially in bachus and adults, we always keep a watch on the lower limb movement because once first 24 hours the movement is secured, then we are good to go. Then the risk of paraparesis due to non-targeted Adam Kiewicz embolization is gone. And I believe this child, I think eventually she recovered well. I think Indu ma'am will tell you the further part.
Thank
Yeah.
you so much. That was really very enlightening.
Yeah. Ma'am, just before concluding, one or two points I wanted to highlight for the audience, that whenever you see this kind of AV malformation in the lung, always look at the upper abdomen vasculature, especially the liver, and you should rule out the syndromic association like Osler-Weber, Rendu, which can have pulmonary as well as AVMs in the in the liver also. So just wanted to share one case that we have seen. Uh,
Uh, doc, Dr. Hiren, can you stop share? Then I will share
I'll
mine.
stop share. Yeah, I think
Yeah,
you have to stop share.
yeah. I will just start sharing mine. So thank you. That was really a very wonderful way of managing it, and I think Dr. Monil did a really great job. I will now quickly, for the want of time, I'm going to rush through this presentation, but I'm going to review pulmonary artery variants, a little review of literature. So hemoptysis in children is really not very, my slides are seen, right?
Yes, ma'am.
Yeah,
Yes,
so
ma'am, you can see yours.
hemoptysis in children is really not very common, but we've had 30 cases of hemoptysis in the last 2 years, and I think probably it could be a referral bias. And we had 15 children with cystic fibrosis who had hemoptysis, 3 who had a post-TB bronchiectasis causing hemoptysis. We had 4 with idiopathic pulmonary hemosiderosis, 1 lane Hamilton. 3 were factitious, and they were the most troublesome because to come to a diagnosis was really very difficult, and we had to go through the gamut of all investigations. 3 were post-BMT, diffuse alveolar hemorrhage, and 1, this child was a pulmonary AV malformation. So we looked at this article, which was a systematic review of 171 patients, and in their group of patients, infection was on the top. That is, 65 children had infection, 55 had some other causes, 20 were unknown, heart disease, neoplastic causes, upper airway bleed, cystic fibrosis, and trauma was there in their group of children with hemoptysis. And then they did a split up of children with infection where pneumonia and bronchitis was on the top, followed by pulmonary TB, bronchiectasis, and upper airway bleed, lung abscesses, and laryngitis. So coming to pulmonary arteriovenous malformations, these are structurally abnormal vessels that to provide a direct capillary-free communication between the pulmonary and the systemic circulation right into the heart. So basically, it is a right to left shunt. So this is what we need to clearly understand, that PAVMs, that is pulmonary arteriovenous malformations, connect from the left side, from the right side of the heart, that is from the pulmonary trunk, directly into the left atrium, and therefore it bypasses the capillary bed. The prevalence, I was shocked to read it myself when I reviewed literature, that 1 in every 2,600 individuals could actually have a PAVM. And we are picking up more of these because of the advances in imaging techniques. So if you have more of the Hiren Panwalas and the Dr. Monils in the world, we will probably have something like a similar prevalence that we may identify. The etiology could be genetic in the form of hereditary hemorrhagic telangiectasia. So 70% of the PAVMs occur due to the hereditary hemorrhagic telangiectasia. So if you have an HHT, you have 70% of the PAVMs belong to this category, but you can have acquired PAVMs in congenital heart disease, gestational trophoblastic disease, chronic liver disease, associated with TB. Wherever there is necrosis in fungal infections like actinomyces, you could have a PAVM. Pregnancy is also a risk factor for PAVMs because of the angiogenesis which can occur during pregnancy. So this is a very beautiful representation of what happens in a PAVM. So from the pulmonary artery, ideally, which comes out from the right atrium, you need to go through the pulmonary vascular bed before you enter the left side of the heart. So from here, if you see from the pulmonary artery, this arrow here indicates right from the pulmonary artery, you are entering, you're bypassing everything and directly getting into the pulmonary vein. So why do we need this diffuse capillary bed? We need it basically for gas exchange. So when you look at the pathophysiology, you will understand the symptomology of the PAVMs. So you need it for gas exchange, for getting in oxygen into the blood and washing out CO2. It is a huge mechanical filter. So small emboli can be filtered here. Toxins can be filtered here. Bacteria can be filtered here. And it also, this capillary bed also aids the metabolic function of the lung. So there's a big role of this capillary bed, which also lowers down the pressure of the pulmonary artery before the blood flows into the pulmonary vein. So if you bypass this, your symptoms are exactly because of this pathophysiology. So you will have hypoxemia because it's a right to left shunt. You'll have dyspnea because of the right to left shunting. And because the filter function is gone, you can have a paradoxical embolic event, which could be like a stroke. And if there is any infection, you could have a cerebral abscess because of the unfiltering blood which enters the systemic circulation. You can have hemorrhage here because the pressure of blood coming out from the pulmonary artery is huge. It's a vein, and that can kind of, because the capillary bed is not there in between, it will move out of into the alveolar space, causing hemorrhage and also causing hemoptysis. Quickly to go through that, it is an autosomal dominant HHT. can be autosomal dominant, or it could be sporadic. In our kid, we did not have any family history, so it probably was sporadic, and there are multiple genes which are involved, and the mutations basically affect the TGF beta signaling pathway, which is crucial for vascular integrity and development. So it's an autosomal dominant condition with high penetrance, but you could have a variability in phenotypes. You could have small AVMs, which may be asymptomatic, and there is a two-hit hypothesis. Like there, you should have a genetic mutation combined with an external trigger, which could be inflammation, trauma, angiogenic stimuli like pregnancy, which can contribute to an AVM malformation. So it could be a cause for acute embolization and death in a person who is pregnant, who has an underlying AVM which can get triggered off due to the stress of pregnancy. The majority of the PAVMs are caused by hereditary hemorrhagic telangiectasia, which is also called as Osler-Weber-Rendu syndrome. It is autosomal dominant, and if you look at the prevalence of HHT, is 1 in 5,000. If you look at the prevalence of PVMs, it is 1 in 2,600, because 70% of the PVMs belong to the HHT category. When you have an HHT, you can have, as Dr. Hiren mentioned, you could have AVM seen in other organs beyond the lung, but the lung is the commonest. But you can have AVMs in the liver and the brain, but pulmonary AVMs are more frequent. So in this patient of ours, we did do a screening MRI, and we did an ultrasound of the abdomen to look for, and Dr. Hiren scanned through the upper abdomen to look for AVMs in the liver as well. We did not find any in this. There is a Curaco criteria for diagnosing HHT, and you need 3 of the 4 criteria to be definite about the diagnosis of HHT. If you have 2 criteria which are positive, then it is a possible diagnosis, but if you have less than 2 criteria, it is unlikely. The criteria include epistaxis with spontaneous recurrent nosebleeds. So it's very common for us to have children who have recurrent nosebleeds, and most of the time we may just pass it off. But you must remember that AVMs could be an underlying etiology, and HHT could be an underlying etiology for these nosebleeds. You may have telangiectasia, which are small blanchable red spots, typically in the location of the lips, oral cavities, fingers, and nose. You may have visceral AVMs in lungs, liver, or brain, or even in the GI tract. You may have a family history of AVMs. So if you have 3+ of these criteria, you're likely to diagnose HHT. Mind you, though it is autosomal dominant, it has a variable disease severity even within the same family, because though it is highly penetrant, but it can be still variable. And you may have a child who may present to you with epistaxis only. And as the time goes by, these children may develop telangiectasia, and they may develop malformations, AV malformations later. So you may have to follow up. And if you have a very strong family history, it is worthwhile doing a genetic testing. Pulmonary AVMs are the most common site, and often than not, it is in the lower lobes because of the increased blood flow and pressure. Our child had it in the upper lobe, but the more common site is in the lower lobe. As I've already mentioned, the reason why you have hypoxia and neurological complications because of paradoxical embolization, which can lead to brain stroke or abscesses, and pulmonary hemorrhage, which are less common in children. AVMs could be simple if it is fed by a single segmental artery, but in our case, we had a complex AVM which was being fed by multiple arteries. It could be asymptomatic. You could have something called as orthodeoxia. That means when you stand up, you have worsening oxygen levels because the flow through the AVM increases when you stand up, and therefore you may have more hypoxia, and this could be a characteristic finding in a PAVM. This I've already mentioned, so I will not repeat it. Brain AVMs can present with migraine, strokes, seizures, focal neurological deficits, or you could have a hemorrhage. It could be intracerebral or subarachnoid hemorrhage. Brain MRI screening is recommended for early intervention because the outcomes could otherwise be catastrophic. Hepatic AVMs, more commonly seen in adults, especially by the HHT2 type of mutation. Again, it could be asymptomatic, but if the AVM is of large volume or complex, you could have a high output cardiac failure, portal hypertension, or you could even have a biliary disease. Diagnosis can be done even by a simpler Doppler ultrasound. So when you have a patient, when you're suspecting an AVM, You could do an X-ray chest, but an X-ray chest is very less likely, it's not easy to pick up an AVM or an X-ray chest unless you have a high index of suspicion, a family history. You can do something called as a transthoracic contrast echography, where an agitated saline is injected to the through a vein which goes from the right side of the heart to the left atrium. So you can identify these bubbles in the left atrium very quickly because of the shunt, because of the AVM shunt. So this could be a screening tool, but nowadays we quickly go on to a chest CT to diagnose AVMs. But this could be an initial screening tool, and there is no radiation exposure to the child when your diagnosis is not sure and when you're suspecting it. But it has its limitations of sensitivity and specificity. Even if you do a chest CT without contrast, you can identify an AVM, but contrast will definitely highlight the AVM much better. But even with a simple chest CT, you can take a MIP view, which is called the maximal intensity view, which can show you the vascularity of the pulmonary vasculature, and you can identify a AVM. You can also, if you are not sure on a chest CT with contrast, you can also do a CTPA. Brain AVMs and liver I've already highlighted. So this was a very nice X-ray which I took from a textbook. So here you can see you can actually see on a plain X-ray this structure here, which is actually a pulmonary AVM, and this is your feeder vessel, your artery and your vein. So this is how it would look on an X-ray, and it could be so non-specific that you can easily miss it, like we did in our case, where the X-ray chest, I think it needed Dr. Hiren's eye to say that there was something abnormal there, and we had passed it off as normal. So this is like an algorithm on how you will diagnose an AVM when you have an index of suspicion. You could do a chest X-ray, you could do an oxygen assessment, you could do a transthoracic 2D contrast echo. But of course, the most important test is a CT scan with or without contrast, which could identify an AVM. I think treatment has been highlighted very beautifully by Dr. Monil, where we do an embolotherapy, a transcatheter embolotherapy. If you have an AVM more than 3 millimeters, you should do, or a symptomatic AVM, you should do embolization, and it improves oxygenation exercise tolerance. It's safe in children in the hands of experts, but you need to follow up these kids. So here we use a dual, we used an embolization as well as a coil. So when you use both the procedures together, the risk of recanalization is reduced. But it's important that we need to also prevent complications, like because there is a risk of an abscess, like a paradoxical embolization with a formation of brain abscess. Antibiotic prophylaxis before doing any dental procedures, etc., should be done. Avoidance of scuba diving, because that can increase the risk of paradoxical gas embolism, and IV line filters to prevent air embolism in these children, because they have a malformation which can then directly cause embolization. We need to follow up these kids, because if you have not done anything for them, if it's a small PVM, they can grow in size, and therefore periodic rescreening may be recommended. Even in asymptomatic patients, once in 5 years, a rescreening is recommended, and more frequent can be done depending on the patient, on whether it's a high risk patient or whether the patient is likely to be more symptomatic. Pregnancy could be a very problematic area if you have a patient with an AVM, and because there could be increased risk of complications during pregnancy, which I've already mentioned. There are some articles which mention that the CT angio may have to be repeated even after every 3 years. Yeah. So these are the references, and thank you very much. If there are any questions, I would like
Thank you, ma'am. Thank you, ma'am, for that excellent comprehensive review of literature. So before we end, there are 2 questions in the chat box. One of them, which is mine, is answered already, of how often we follow up the child once in every 5 years of asymptomatic. The second question is from Dr. Sonal, ma'am. Is any further workup required or underlying genetic test only?
Yeah, I think it's the
No,
genetic.
I meant for this child, for this
For this
our
child.
child. Like, do we need to do any further workup since she is presented with a bleeding AVM at such a young age? So, any further test, like, genetic workup, she may have AVMs elsewhere or whatever, is it required, is my question.
We have sent her genetic testing. We had done an MRI brain to look for AVMs in the brain, which are not there, fortunately. Ultrasound and even CT abdomen also was looked into for visceral AVMs in the liver. fortunately, which she doesn't have. And there is no family history. We are keeping this child on a follow-up. We did speak to Dr. Monil about when we should do a repeat test. He was very confident he may not require it, but we are following up this child.
Thank you, ma'am. Are there any other questions? So, if
Doctor,
there are,
yeah,
we'll conclude, ma'am. There are no other questions.
we can have the last word from our president.
From Dr. Rawat sir, if you would like to share your opinion on.
Thank you very much. It has been excellent session, excellent learning, great radiologist, and I think this will really solve the mystery in future in children with pulmonary bleeds. And I think the session went very well, and we hope that such sessions would be in future also. And best of luck. Thank you.
Thank you very much, and thank you everyone who joined in early in the morning today.
Thank you, ma'am. Thank you, Hiren sir, Sonal ma'am, and Monil sir for their excellent comprehensive talk.
Thank
It was good.
See you next time. Bye bye.
Bye bye.
Have a good
Bye
day.
bye. See you. Bye.
Thank you, IAP. Thank you.
Yes.